Welcome. This second section will be focusing on assessment of the patient in relation to risk of pressure ulcers. We'll focus on what we need to know about the patient to help us make a successful plan for prevention. We will look at risk factors for pressure ulcers with a focus on patients with significant fragility fractures, such as hip fracture. All health professionals, and especially nurses, know that assessment is the first step in planning effective care. Without an understanding of the patient and their individual risk factors, care will not meet their needs. The main purpose of assessment is to inform an effective preventive plan. We use assessment to help us understand the individual patient risk factors so that we can provide evidence-based care according to those individual needs. Even so, it is important to stress that assessment on its own is not enough to reduce the occurrence of pressure ulcers. It is the prevention interventions identified by the assessment and plan that are the most important factors in successful prevention. There are two main aspects of assessment. The first is skin assessment, the process through which the state of the patient's skin is recorded on an ongoing basis. The skin is then monitored so that problems can be recognized early. The second aspect is risk assessment, the aim of which is to identify specific intrinsic and extrinsic factors which require preventive interventions, many of which we discussed in the first section. A full assessment of the patient's skin should take place as soon as possible after admission and then as part of every risk assessment, or more frequently if the patient's health deteriorates or healthcare interventions such as procedures or surgery increase the risk of pressure ulcers. Skin assessment should focus on common pressure points over bony prominences, such as the sacrum, buttocks, heels, the back of the head, elbows, shoulders, hips, ischial tuberosities, the sides of knees and ankles. Any red or discolored skin over bony prominences indicates possible tissue damage and must be acted upon immediately to prevent deterioration. In the UK, this has been called the React to Red campaign, and we'll discuss this in the next section. Any existing or new pressure ulcer should be recorded and classified according to the international classification system. It is essential to recognize early signs of damage in persons with darkly pigmented skin, as those with darker skin tones are more likely to develop pressure ulcers than those with lighter skin tones. It is extremely important to address the knowledge gap that exists for many practitioners relating to assessing and identifying pressure ulcers across the diversity of skin tone and how this affects risk for individuals. As part of the skin assessment, it is also important to recognize the different presentation of skin that is damaged by moisture. This is called moisture-associated skin damage. In fact, this term is used to refer to what is an irritant contact dermatitis. It looks very different to skin injury caused by pressure, shear and friction alone, but may occur alongside pressure injury. The most common irritant is urine, but the list can also include feces and other fluids. There are several different types of moisture-associated dermatitis. The most common form is linked to incontinence. It is the result of prolonged exposure of the skin to urine or feces and is a form of irritant contact dermatitis. The moisture itself and the chemical irritants contained in urine and feces alter the skin pH level so that it becomes more alkaline. This reduces the barrier function of the skin and depletes infection defenses. Incontinence-associated dermatitis is often mistaken for a stage 2 pressure ulcer, as will be discussed in section 4 of this session. Prevention and treatment of this kind of skin damage are different to other causes, so it must be diagnosed correctly and appropriate care must be planned and instigated. The international guidelines tell us that patients with limited mobility, limited activity, and high potential for friction and shear should be considered at risk of pressure ulcers, just as we outlined in the first section. This includes all patients admitted to hospital with a hip fracture who are subjected to significant pressure, friction, and shear. Pressure ulcers are a common complication of hip fractures and hip fracture surgery. The risk increases significantly when the patient undergoes surgery and in the early post-operative period because of the additional impact of both the intrinsic and extrinsic factors. The international guidelines recommend, firstly, that a structured risk assessment is carried out. This needs to happen very soon after admission to enable identification of risks of pressure ulcer development. In particular, this should identify the patient's specific individual factors on which prevention interventions should be based. The guidelines also recommend that a risk assessment should be conducted after every change in health status, such as during and following surgery, or in case there is a deterioration in general health. The structural risk assessment should include consideration of both the intrinsic and extrinsic risk factors, such as those listed on the right side of the slide. As you may see, nutrition is highlighted because a nutritional assessment is particularly important, as we will discuss in section 3. Medical devices such as caths, catheters, and IV lines are a source of intense pressure on the skin and can lead to a specific type of pressure injury. These are known as medical device-associated pressure ulcers. It is essential that the presence of any medical devices is recorded as part of the risk assessment so they can be included in the prevention plan. When thinking about pressure ulcer risk assessment, nurses and other health professionals will usually think about risk assessment tools. The advantage of such tools is that they provide a structured approach to assessment. Besides, they have been in use for around 40 years in many countries. While they provide a quick supplement to clinical judgment, there is a need for caution here. The international guidelines stress the need for a comprehensive assessment, which these tools often fail to provide. It is recommended that all additional risk factors are considered and that the outcomes of assessment are interpreted using clinical judgment. The international guidelines do not specifically recommend the use of any specific assessment tools, and for this reason, we will not do that here. The most important question is whether the use of a risk assessment tool reduces the actual incidence of pressure ulcers. Moore and Patton conducted a Cochrane review of the evidence which was published in 2019. They found that despite the many decades that risk assessment tools have been in use, there were only 2 studies that evaluated whether the use of risk assessment tools reduced the incidence of pressure ulcers. They found uncertainty about whether the tools assessed in the studies made any difference to pressure ulcer occurrence when compared to clinical judgment. Their final conclusions were that, given the evidence available, risk assessment tools cannot be assumed to reduce the incidence or severity of pressure ulcers. In terms of your own practice, then, it is recommended that you should use the risk assessment tool recommended locally or nationally in your area. You should use this tool to structure your assessment, but not rely on it on its own. Your assessment should focus on the risk factors you identify rather than the particular level of risk and the numbers calculated by the tool. Most importantly, you should make sure your risk assessment translates into a plan and interventions that modify the risk factors you identify so that pressure ulcers are prevented. Take action and keep your patients safe.